Hello everyone. In this video, I'm going to talk about atrial fibrillation. It is a heart condition that causes an irregular and often abnormally fast heart rate. The normal heart rate ranges from 60 to 100 beats per minute, but in atrial fibrillation, it may range from 100 to 175 beats per minute. This is how an ECG tracing of a normal heart rhythm looks like, and this is how it looks when there is atrial fibrillation. The rhythm is irregular and erratic, with fibrillation waves between heartbeats. These are tiny and irregular. Here we have an ECG tracing showing the difference between atrial fibrillation, fibrillary waves, and atrial flutter, which shows sawtooth pattern, as we can see here. The various causes of atrial fibrillation may include heart failure, hypertension, cardiac ischemia, myocardial infarction, mitral valve disease, pneumonia, hyperthyroidism, alcohol, postoperative atrial fibrillation, along with rarer causes like cardiomyopathy, constrictive pericarditis, sick sinus syndrome, bronchial carcinoma, atrial myxoma, endocarditis, hemochromatosis, or sarcoidosis. Most of these causes constitute what we call the substrate. Here it is shown the integrated atrial fibrillation mechanisms, how atrial fibrillation actually occurs. We mainly focus on four aspects. This includes the substrate, the causes of which I just mentioned, triggers or initiators, focal ectopic activity, and re-entry. Here is a great flowchart showing how all these aspects get integrated and initiate atrial fibrillation. The substrate aspect, which includes hypertrophy, fibrosis, slow conduction, effective refractory period or ERP, and action potential duration or APD changes, along with various triggers like autonomous nervous system and various hormones, leads to re-entry, which basically refers to the persistence of an electrical impulse as a result of continuous activity around the circuit to re-excite the heart after the refractory period has ended. This in turn leads to atrial fibrillation. Another aspect we need to look at is ectopic firing, which basically means there is a part of the myocardium which is beating independently, and this is triggering an atrial fibrillation. This can occur due to cardiac automaticity, which is the accelerated generation of action potentials either by the normal pacemaker or by an abnormal tissue on the myocardium. Altered calcium handling leads to disruption in the normal action potential of the heart, and also as a consequence this may lead to the formation of EADs or DADs, which are basically early after depolarizations or delayed after depolarizations. We can visualize these as shown in this picture. So all these factors, along with other risk factors which may include genetics, age, gender, obesity, sleep apnea, diabetes, cardiac and non-cardiac diseases, contribute to the development of atrial fibrillation. Also, inflammation and inflammatory signaling has been attributed as leading to atrial fibrillation. And all these factors, in turn, directly or indirectly, cause cardiac muscle remodeling, which hastens this cycle even more. Clinically, atrial fibrillation may present as an increased heart rate, an irregular pulse at 75 to 190 beats per minute. The cardiac output may be reduced because of the loss of atrial kick and excessively rapid ventricular rate. And there can be stasis of blood as a complication, leading to an increased risk of stroke. Although the ventricles contract, sufficient blood pumping to produce a pulse does not occur. So this leads to increased heart rate, but the radial pulse is low. Palpitations may be felt, and rarely chest pain or dyspnea may occur. The diagnosis or investigation for atrial fibrillation is straightforward. ECG is the first line investigation of choice. It shows irregular QRS complexes, no discernible P waves, but the QRS shape and the T wave shape may be normal. Blood tests may also be performed to rule out the substrate conditions, which may include hypothyroidism or myocardial infarction, etc. The management of atrial fibrillation depends on two major aspects. One is the duration of the atrial fibrillation, and the other is the selection of the appropriate approach, which includes either rate control or rhythm control. In cases where the atrial fibrillation is acute, which is less than 48 hours, rhythm control is the preferred mode of management. This may include mechanical cardioversion or medical cardioversion. Mechanical has a higher success rate compared to the medical. A defibrillator is used to give a shock to cardiovert the rhythm. While in medical cardioversion, antiarrhythmic drugs like amiodarone or flecainide can be used to cardiovert the rhythm. Also, an anticoagulant like heparin is used to prevent thrombus formation. In cases of chronic atrial fibrillation, which is more than 48 hours, rate control is the preferred mode of treatment. This includes a beta blocker or calcium channel blocker as first line, and other drugs like digoxin may also be used as second line. Along with this, anticoagulation is must to prevent any thrombus formation. The requirement for an anticoagulant is gauged using a score called Chad's VAS2 score. This treatment is continued for a span of 3 weeks, which is followed by cardioversion as explained in the acute atrial fibrillation treatment. Lastly, in some cases, occasional spells of atrial fibrillation may occur. This is called paroxysmal atrial fibrillation. In these cases, pill in the pocket approach is taken, where the antiarrhythmic drug may be used when the symptoms develop temporarily. With this, I would like to conclude this video. Hope you guys found it useful, and thanks for watching. Stay tuned for more.